Okay. Hi, everyone. Thanks for joining the webinar today. I am Dr. Ong, currently the president of the Malaysian Urological Association. I'm a urologist practicing in the University of Malaya. So today we'll address a very important topic on testosterone replacement. They call it TRT, in the literature, testosterone replacement therapy. And today we have a very, distinguished speaker who will give us some information and insight on how to manage TRT. With us today is Dr. Warren Lu. Dr. Warren, we call him Dr. Warren. We know him very well. He is a key member of the Malaysian urological community. His expertise is in reconstructive and functional urology. So besides seeing those adult patients, he also sees pediatric children as well to address their urology problem. In fact, many of the rehab physician here would refer patient to him, because he treats patient really well. I get all the good feedback, from the doctor who has referred to him. He also, is an expert in robotic surgery, have experience being trained in Peter MacCallum Hospital in Melbourne, and also the Guy's and St. Thomas's NHS Trust in the UK. Those are the two, well-known robotic surgical center. So today, Dr. Warren will enlighten us on the tips and tricks on testosterone replacement therapy. He will use a case-based study approach. So, Dr. Warren, please, the floor is yours.
Right. Thank you very much, Prof. Ong, and thanks a lot, Bayers, for sponsoring the study and also the talk. So, so I believe everybody can see from the screen that I'm just going to start off with my first case, which is Mr. T. Right. This topic is actually very close to my heart because obviously we are at the age of actually needing the Nebido. And of course, it's also interesting because, a lot of people actually have a lot of misunderstanding, myth about this topic. Now, just before I venture further into this topic, I was actually under the impression that, okay, long-term use of, testosterone replacement therapy is going to give us a lot of side effects. I must admit that I was one of those who actually pretty against it from the very beginning. But then towards the end, when, as time goes by, when you have many, many patients that comes to you for seeking help and also to find out whether they can actually benefit from the testosterone replacement therapy, I tend to go more and more deeper in terms of searching and see whether it is really true, whether, all the side effect that is actually shown up from the studies and the trial and the previous journals and all these things, was it true or is there any updated information about it? And to my surprise, there's actually quite a lot of things that I can actually share with you guys. Now, without further ado, I would like to start off with my first presentation. Mr. T is a 46-year-old gentleman complaining of lethargy, inability to stay focused and feeling less energetic for the past few years. He was not able to achieve a good erection many times and occasionally feel that he is totally disinterested in sex. He has a daughter, aged about 6, but he was hoping to have another child. So the wife claimed that he was very temperamental over the past few years and has demonstrated signs of progressing depression. Now, there is no significant medical or surgical history. Routine medical checkup seems to reveal nothing remarkable. His father was diagnosed with prostate cancer 2 years ago and had radical prostatectomy done. He too had his PSA checked regularly and it was 2.5 nanogram per milliliter, and his blood testosterone level was 250 nanogram per deciliter. He was then advised on the testosterone therapy. So he consulted a few urologists. Some were of the opinion that he should not be considering the testosterone replacement therapy because his father has prostate cancer. Others felt that it may not be a good idea because since he wanted to have a second child. Now, he took up the challenge anyway. He dropped the idea of having a child, the second child. So he took up the challenge of embarking on the journey of testosterone therapy. and he actually went on for about 4 years with this testosterone replacement therapy. He had his PSA checked regularly and his prostate examination done by the urologist performed every 6 monthly, and he was informed that it was all normal. So he felt energetic, and since then he has been more actively participating in sports. His circles of friends found him more sociable, fun-loving as compared to before, and a wife also found that he seems to be a bit more interested in being intimate with her. Now, one of his friends who was on testosterone replacement therapy for about 8 years suffered from a cardiac arrest recently and was told by the cardiologist that the exogenous testosterone supplement could have caused it. Another friend from the same circle was also diagnosed to have prostate cancer and incidentally was on a testosterone therapy for 6 years. Now, he browsed through the websites on testosterone replacement therapy and was very concerned that how it may one day cause an impact on his health and the long-term side effect of it. He's at a crossroad now, wondering whether he should be stopping his testosterone replacement therapy because of the risks involved. And he's also started to think about, having a second child as what he wanted. So now, big question is that, what are actually the long-term side effects of the testosterone therapy, especially for us who are in our middle age and also elderly patients who have demonstrated symptoms or signs of hypogonadism. So to date, many physicians were still inquiring about the best approach and care for the symptoms of hypogonadism. Most of us are still conscientious about its side effect, just like me, what I mentioned earlier on. Testosterone replacement therapy, when given to appropriate selected patients, always come with caution because they need to be monitored very vigilantly. Now, we all know that the side effects of testosterone, mainly you can see the acne, oily skin, salt and water retention because it's steroids, stimulations of the prostate growth, prostate cancer risk, breast enlargement, gynecomastia, testicular shrinkage, sleep apnea, increased risk of blood clots, and eventually leads to heart attack and strokes, and of course, the mood change, being very temperamental and showing aggressive behavior. Now, are these true? What are the studies? So if you were to look at the previous journals, it's all showing the side effect and the risk of testosterone replacement therapy. Okay, so I just shown up a few journals here. Nobody seems to be saying that the testosterone replacement therapy is actually beneficial without the side effects. So you got to wait it out and see, because it may benefit the patient to a certain extent, but it also gives a lot of side effect to the patient as well. So now, what are the myths and facts? Can the testosterone therapy make me feel more energetic? And the long-term risk of testosterone replacement therapy? Is it true that the testosterone therapy is beneficial for the treatment of metabolic syndrome? Can I use the testosterone therapy for erectile dysfunction? Can I continue with the testosterone replacement therapy if I wish to have children? How do I monitor the testosterone therapy? Can testosterone be used if I have family history of prostate cancer? And how long do I need to continue with the testosterone therapy? So as urologists, I believe, same with Ong as well, we frequently being bombarded by patients with all questions like this. Now, testosterone level with reference to age, and over here I use the nanogram per deciliter. So you can see that when you're much younger, your testosterone level is peaked. And obviously, after 30 years old, you start to drop your testosterone 1% per year. So you can see that at the age of 85 to 100 years old, very elderly, they can still have a very acceptable testosterone level, even though they are supposed to have a declining trend. Testosterone deficiency has a prevalence of 10 to 14% among adult males, and 20% were among men aged 15 to 39 years. The low testosterone actually affects almost 40% of the men aged 45 and older. All right, so we are not spared. Statistically, 2 out of 10 men over 60, 3 out of 10 men over 70, and 3 out of 10 men over 80 years old suffer from hypogonadism. Now, how do you diagnose this late onset hypogonadism? That is a testosterone deficiency syndrome. First of all, you got to have, number one, a testosterone level of less than 300 nanogram per deciliter. And some actually say that 350 nanogram per deciliter. That is fine. Depends on which guideline you follow. So over here, we follow the European Urology Guideline as well as the American Urological Guidelines. But they both mentioned that not just the testosterone level that you need to check, the patient needs to have the sign and symptom that is suggestive of testosterone deficiency syndrome before you could advocate the replacement therapy. Now, what are the signs and symptoms? Reduced energy, reduced endurance, diminished work and physical performance, feeling fatigued, feeling depressed, reduced motivation, poor concentration, impaired memory, irritability, infertility, reduced sex drive, and of course changes in erectile dysfunction. And most of them end up with various degrees of erectile dysfunction. Now, how do we assess? First of all, you can see, look at him as a whole. Look at his virilization status and examine his body hair patterns. And of course, also find out whether he's putting on more weight. Because, you know, as we lose the testosterone, we tend to build more fat and we tend to lose muscle, all right? And also you need to examine his testicular size. And of course, you need to see whether he has gynecomastia, and not forgetting the fact that his prostate needs to be examined as well. So who should go for the testosterone level checked? Those patients with a history of unexplained anemia, bone density loss, diabetes, exposure to chemotherapy, radiotherapy or chemotherapy to testes, history of chronic narcotic use, infertility, pituitary disorders, and chronic steroid abuse. What about the concerns of infertility? Just like the man. The man who wishes to father a child should be counseled regarding the inhibition of the intratesticular spermatogenesis, because once you use the exogenous testosterone therapy, you basically shut down your own factory. And that's the reason most of them will end up with some form of a testicular shrinkage. Well, for those who really want it, but at the same time also want to have, want to father a child, then sometimes what we do is that we can impose the testosterone therapy together with clomiphene fumarate. SDRM is nothing but selective estrogen receptor modulator. Aromatase inhibitor, such as anastrozole, can be used in conjunction with the testosterone replacement therapy, and that is really just to preserve the spermatogenesis. And fortunately, most men gain back the spermatogenesis once the testosterone therapy is stopped, and only about 10% of the men's spermatogenesis never really recover. And of course, all these things you have to explain and counsel patient very well. So should hematocrit or PSA be checked prior to the commencement of the testosterone replacement therapy? Yes, because from the guidelines it states that if the hematocrit exceeds 54%, the clinician should consider withholding the testosterone therapy until the etiology is formally investigated. And once you have investigated it and you know the cause of it, and if it's still more than 54%, then you may have to think about the dose reductions or temporary discontinuation to prevent the testosterone-induced polycythemia. The PSA should be measured prior to the commencement of the testosterone therapy, especially for those patients who are above 40 years of age, in order to minimize the risk of prescribing the testosterone therapy, because you know that some of these patients may have occult prostate cancer. AUA actually stated that there's no strong evidence to link the testosterone therapy to the prostate cancer. And then the EAU guidelines basically say that you can't prescribe the testosterone for those patients with a low risk of prostate cancer. So now, what about the cardiovascular risk? The current available literature has consistently shown that low testosterone are mostly associated with increased risk of major cardiac events, such as myocardial infarction, strokes, possible cardiovascular related mortality, and increased prevalence of mortality, and of course the arteriosclerotic, the cardiovascular risks. The current literature does not definitely demonstrate that the testosterone level actually increased risk of cardiovascular event. So surprisingly, you would have thought that the Nebido or the testosterone replacement therapy can cause a lot of thromboembolic phenomenon, but the latest literature does not seem to suggest that, because patients who actually have a testosterone deficiency syndrome, basically, they themselves are already at a high risk of getting the myocardial dysfunction, infarction, and even a stroke. So when you are able to use the testosterone to actually bring down those risk factors, basically, you are actually kind of like minimizing or reducing the cardiovascular risk. Now, what about the venous thrombotic event? Since the FDA warning in June 2014, the observational studies have not shown that there's an association factor between the testosterone therapy and an increased risk of VTE. Still, we tread it very cautiously. So the patient, if they were to found to have recent cardiovascular event, when should we start the testosterone replacement therapy? Well, the testosterone therapy with close monitoring should be done to ensure the proper dosing and the safety survey should be considered in this patient only after 3 to 6 months from the cardiac event. We are cautious about this. So will testosterone therapy improve the sexual function of the patient? Yes. And that's the reason why for those patients who have low testosterone therapy, being one of the investigations for those patients with erectile dysfunction, we will actually supplement Viagra together with the testosterone therapy. So whether the testosterone therapy improve the cognitive functions, improve the diabetes, the lipid profiles and all these things, we still do not know. Now, counseling the patients with low testosterone. First thing, lifestyle modification. Advise them to lose weight, advise them to actually stop smoking, drink less alcohol, maybe no alcohol, increase physical activities, plenty of exercises, healthy diet would definitely increase the serum testosterone level. But if the above measure fail to increase the testosterone level, then consider the testosterone replacement, provided they actually present to you with various symptoms of testosterone deficiency syndrome. So how often do you monitor the serum testosterone level? The testosterone level should be measured every 6 to 12 months when the patient is on testosterone therapy, because you know that some of this, the injection, you actually give them every 3 monthly. But some, like for example, the EAU guidelines, they can actually advocate every 3 monthly. So the cessation of therapy should be considered 3 to 6 months after the commencement of treatment if the patient have already reached a normalization of the testosterone level, but the symptoms fail to improve. That means to say that their symptoms may not actually be related to the testosterone deficiency. So for that, you may want to stop the testosterone, because you remember the first diagnosis of testosterone deficiency syndrome, it has to be combined sign and symptom plus the low serum testosterone level. Now, what are the contraindications? For those patients who have breast cancer, for men with a prostate cancer, obviously they are the contraindication. Men with the desire to have children, you know that it shut down your internal factory, which is an intratesticular spermatogenesis, and of course with very high hematocrit level. And those patients with a cardiac failure, obviously you will want to think twice about starting the testosterone therapy. So this is basically a treatment algorithm of patients who actually present to you with the symptoms and also the blood test showing testosterone deficiency. First of all, you need to discuss, find out whether they actually belong to that group. And after that, give them the various options. And of course, you can see that there are many types of the testosterone replacement therapy. You can give gel, you can give patch, you can give injection, and each of them actually have their own pros and cons and of course side effects that you need to know. And of course, there are patients who will go on an alternative, such as the SERM, the beta-HCG, and also the aromatase inhibitor. And of course, after that, you need to monitor the testosterone level very carefully to decide whether the patient need to carry on with the testosterone replacement therapy or they can stop. Now, so there are many studies nowadays to actually advocate the long-term use of injectable testosterone therapy. So you can see that this basically is a study done quite recently, and it shows that it actually produced an improvement in the body weight, waist circumference, and also the body mass index. And of course, it also does show some evidence of reducing the fasting blood sugar. You know that previously when I mentioned that it's a little bit debatable, currently more journals seems to be more pro the injection rather than saying that it's still very blur about this. Now, it is also improving the lipid profile as well. Now, more and more studies have shown that the elderly men with the hypogonadism and erectile dysfunction with the testosterone therapy actually reduces the obesity parameters and also improves the metabolic syndrome. Now, these are the few journals that actually show that. And of course, when it comes to these patients with an obese hypogonadism man with the type 2 diabetes, we use the testosterone therapy, okay, because we think that they actually can reduce the metabolic syndrome. Now, more and more studies of this testosterone undecanoate injection, especially in those men with hypogonadism. It seems to show that it not just improves the erectile function, but it also reduces the risk of major cardiovascular event, as what I mentioned earlier on. So now, quality of life, obviously the sexual function will be much better with the testosterone replacement therapy if it just shows up that the patient does have a low testosterone level. So with that, I would like to end my presentation. I'll pass the to Prof. Ong.
Hi. Okay. Thanks. Yeah. Thanks to Warren. Yeah, for that comprehensive coverage. Yeah, on the topic of testosterone replacement therapy. So if you have any question, yeah, please put in the Q&A or the chat box, and we will try to address that. Yeah. And then, of course, there are, of course, throughout many years of giving talk and sharing experience with everyone. So there are a few FAQ, that we face, in our daily practice, our practice and also your practice. So what we're going to do is I'm going to share a few, FAQ. I just need to share screen. Yeah, maybe Warren, you just stop your sharing.
Right.
And I can share my screen. Yep. Okay. Yep. Let me share my screen. Okay. Sharing screen. Yep. Here we are. Yep. The FAQ. Yeah, they are. Okay. Let's have a look at the FAQ. Yep. Oh, let's see. Okay. Wait. Okay. Okay, what is the ideal approach? We'll come to that later. Actually, this should be the last question. This one. Not only people will ask you, your patient will ask you, do we need that kind of long term? Or we just jab a few months or a few years, then we stop. What is the current understanding on this? Yeah.
Well, I would say that the most of the time, that when we give the injection testosterone, we will actually monitor them. So not just to ask them about the signs and symptoms, whether there's any improvement. At the same time, we also test their serum testosterone level. So if you were to ask me, will all patients require long-term therapy? My answer is no, because some of them actually does show evidence of improvement. And most of the time, I would actually just give it to those patients who really genuinely feel suicidal, less motivated, and then they feel that they really cannot get on with their life. And then I would actually consider the testosterone therapy. So if they are actually back to their normal path, I would consider, with, of course, the normalization of the serum testosterone level, I may just withhold the testosterone injection therapy. So it's not exactly a long term, but I do have patients who stays on the injection for many, many, many years.
I think we all have such patients who is very keen, and very compliant. You're so surprised to see they are very compliant. Like I have one patient who keep coming, whenever you see if energy level low, you come already. He said that this thing give him the energy,
the basically.
Okay, all right. We will come to the next one. So so this is the monitoring approach. Yeah. So this is to just you have mentioned that in your slide, but it's good that we can highlight the key point. Yeah. And then so everybody can use your tips and tricks.
So most of the time, apart from the history that we get from the patient, whether there's any symptoms improvement, at the same time, we also will actually check their blood test. So PSA is mandatory. And then, of course, the hematocrit as well as serum testosterone level. So we'll do it prior to us starting. And then after that, we will actually check it every 6 months or 12 months. Then, of course, there are some guidelines who advocated a little bit earlier, really just to find out whether the patient suffers from polycythemia or whether the PSA is constantly increasing, leading to some form of a suspicion that the patient may have some occult prostate cancer. Then in that case, we may want to withhold the therapy. Even though at this moment of time, the AUA guidelines seem to say that there's no obvious linkage between the testosterone therapy and also the prostate cancer. It doesn't actually promote the prostate cancer. But the EAU guidelines seem to say that it is okay to give it, but consider those patients who actually only have very low risk, then you can give. So if you were to ask me about the monitoring approach, I would say that yes, apart from seeing them, I also will need to get the blood test done before and after.
Okay, thank you. So I think that the key point, if you summarize, is how you monitor the testosterone. The other blood to monitor will be the hematocrit, hemoglobin, hematocrit. Next one is I think it will be the PSA. Yeah, do I get that right?
Correct.
Right.
You're absolutely right.
Okay, because sometimes in the clinic, a busy clinic, you are thinking, hey, what should I test? So it's a simple trick, tips to everyone. Yeah, see whether make sure you monitor the testosterone. Number one, number two, make sure you monitor the hematocrit or hemoglobin. Number three, you monitor the PSA if indicated. Yep, so I think that is a straightforward thing. Yeah, in terms of testing, blood test. Yeah, of course you check other clinical parameters as well. Yeah.
Correct.
Okay, there we go. Okay, so key risks. Yeah, you mentioned a bit earlier on, the key risks, So, it's also in your slide, So, but I think it will be good that we just emphasize the key point here.
Yeah.
I think maybe you start with cardiovascular risk first. Yeah.
I think just like when I first started my presentation, I mentioned that I'm actually not one of the advocator for the testosterone therapy because of the risks involved, because there are a lot of myths that come together with it. So when you browse through the journals, and you will see that all these side effects, the adverse events, are a little bit of an outdated studies. The recent studies seems to say that there is no evidence to suggest that. So we know that if a patient were to diagnose to have a low testosterone level, it is itself already been associated with a lot of cardiovascular, risk factors, that they can actually have a myocardial infarction. They can also have strokes and all this, because low testosterone level actually predisposed to those things. So in a way, if you are treating their testosterone level, they're basically minimizing their progression towards that path. But itself, whether the testosterone therapy can increase the thromboembolic event that actually leads to stroke and heart attack, at this moment of time, there's no proof. Because that's why the FDA since 2014 said that, okay, we have to be very cautious about it. But ever since then, there's no replications of that kind of a statement or the journals that suggest that it actually is very strongly related to a cardiovascular. Because the recent study all say that there is no direct or very weak link between the cardiovascular event and with the testosterone therapy. Same thing goes to the prostate cancer as well. Even though we monitor the PSA just like the normal monitoring for every man with above 40 or 45 years of age. We monitor them, but the reason why we monitor them is because in the event, if they actually have strong family history or they are actually going towards the prostate cancer because the PSA levels start to escalate, then we have to withhold it. So it's like we do not actually avoid the testosterone therapy just because the patient actually have a family history. No, we just monitor them just like any other man that we are monitoring, because we may want to consider stopping it. Because remember, our Nobel Prize winner, he was talking about the testosterone, which is one of the reasons why the prostate cancer spread. So ever since that, we say that we are very cautious about it. So if anybody were to have the PSA raised, we will tend to actually withhold the testosterone level. So if the patient were to found to have established prostate cancer, and then if the patients were to found to have this localized or even a metastatic prostate cancer, we will definitely stop the testosterone therapy.
Yeah, all right. I think this that's the current understanding of the situation. Yeah, that it should not have unnecessary risk in a normal patient. Yeah. In terms of cardiovascular risk, in terms of prostate cancer risk as well. In fact, I'd like to share, this morning actually, I'm in a non-stop meeting. And morning, there's a meeting with University of Tokyo and also about 13 Asian countries on this prostate cancer registry. And then, this is a yearly meeting for the last 7 years. And then the Hong Kong expert proposed a study, because from their own study and from the literature, they test the patient. Once the patient is diagnosed with prostate cancer, then they test the testosterone level. Apparently, those patients with low testosterone to start with before when they are diagnosed with prostate cancer, before they start any treatment, those with low testosterone at the very beginning seems to do less well meaning if you're low testosterone, actually it's not good one. We always thought, oh, this patient must have high testosterone, that's why he got prostate cancer and all that kind of thing. It might not be true one,
Yeah, it may not be true. That's why there's a lot of myth out there that actually stop us from giving the testosterone replacement therapy, because we're always under the impression that it's probably going to promote cancer, it's probably going to cause the thromboembolic event and then leading to the heart attack and stroke and all these things. But it is actually not true.
Okay. All right. Okay, we'll get to the next one. Yeah. Okay, issue dependency. Oh, yeah. Is it a constant dependency, tolerance? Is that a concern?
Well, I would say that if you actually been depending on the testosterone therapy, a sudden withdrawal, you will probably feel something. So usually when the patient is on the long-term, the testosterone replacement therapy, what I do is that I will actually scale it down very, very slowly. So I will not just stop abruptly because they will suddenly get a little bit of a withdrawal effect. So what I will do is that I will just maybe, instead of every 3 months, and of course, this is just my own practice, I will just say that maybe you use it every 6 months or something like that, because, the testosterone is like an energy drink to us. So once you stop it very abruptly, you just feel that, okay, you kind of like spring back again. It's like having some form of a withdrawal. So most of the time, I would just slowly scale it down. But in terms of the tolerance, I think that, I think all my patients so far has been tolerating the testosterone therapy well.
Okay, good. Thank you. So I think, okay. Yeah, this is important question, right? It's important question. You address a bit in your talk, your first few slide there, in that particular patient, but that patient give up, But how about those who really want to have kids, It's a challenge, isn't it? It's a challenge, huh?
Yeah. Yes, it is. So that's the reason why I mentioned that for those patients who really need to have a testosterone replacement therapy and also want to actually maintain their spermatogenesis, we can actually give the beta HCG and the chromatin citrate and the aromatase inhibitor and also the selective estrogen receptor modulator together with the testosterone replacement therapy. That to a certain extent will actually maintain the spermatogenesis. There are also many studies have shown that if you were to stop the testosterone replacement therapy for about 6 months, your spermatogenesis recover. And those who does not actually see any recovery only amount to about 10%. So that's really not a lot. So please don't think that, once you stop it, then obviously you're not going to have kids anymore. But obviously it also depends on, how long a term that you've been using this testosterone therapy. Because if you shut your factory down for too long, then may not be a possibility, I would say.
All right. So just don't stop the factory. Yeah, don't stop the factory. Don't have a MCO to your factory. Yeah. All right. I think what we do now, I will just stop here. Because in the chat group and there are good questions. There are very good questions from the audience. We will spend the next 10 minutes or so to address them, so everybody can learn together. So I will put forth the question here. Okay, I think we start with the more straightforward one first to the more complex one. So the question number 1. Will testosterone replacement therapy cause low white cell count? Yeah,
not that I know of. It's definitely not in our study product. I mean, it's not in our guidelines that the white cell need to be something that we checked.
Okay, so that is no. It should not. It should not. Yeah.
It should not.
So So the next question is relevant. Yeah, clinically, what do you do? With patient who has mildly high hemoglobin after the testosterone replacement therapy, mildly high. So what should we do? Yeah.
I don't think that the hemoglobin is the thing that we are looking at. We are more looking at the hematocrit level, and we want to see whether the patient actually have a tendency to go towards the polycythemia. As I mentioned to you, there is a cutoff point of 54. So I don't think that I actually look at the HB. I actually look at the hematocrit rather.
Okay. What's the cutoff there? Maybe just enlighten us
54.
For revision.
54.
54, 54. Okay. We just keep that in mind. We'll just keep that in mind. Yeah. So 54, 54. Okay. So let me check. Yeah. There are number question. Next one. Okay. The next one also important. Yeah. Just now mildly, elevated. So if the hematocrit is beyond 54, polycythemia, what should we do?
First thing, we need to actually find out what is the cause behind this polycythemia. There are many reasons behind the polycythemia. And having found that out, and then if you can address the issue, will be fine. But if the patients have this persistent polycythemia that you think that is never going to come down, then is it safe? I would say that it's probably not safe. So in that case, we will have to do some adjustment onto the testosterone therapy, either reducing the dose or with off it altogether.
Yeah, I think it's important. Yeah, if any doubt, just stop it. I think, right? I mean, if there's any doubt, just stop it. Just stop and then monitor. Yeah, see whether it come back. So it normalizes. Yeah, I think that is the practical point. Yeah. So this next one is a very interesting and relevant. Might not be easy to answer. It said, the question say, I have been losing hair. Yeah, with testosterone replacement therapy. Yeah, how can I manage this and how can I regrow my hair? I think it's a very important question. Yeah, although it's a tough one. Warren, your opinion, please?
Well, you got to wait it out. You know that the testosterone therapy is nothing but steroids. So what is the side effect of steroids? You obviously will lose hair, you have alopecia, and you have gastritis and any side effect that comes together with it. So if you really think that the testosterone therapy is making you losing hair, then consider also other things that will promote the hair. For example, use the minoxidil, something like a local therapy, and see whether it actually helps it. But you have to actually consider your priority, because if you think that the hair is more important for you, you may not really want to continue with that, because it is a known, side effect that comes together with it. But if you think that that is not so much of an issue, that you can get a Victor, you can actually get the minoxidil, or either oral or even local therapy on application, then it's fine. It's fine. So manage your own expectation, I would say.
Okay. Yep. I think it's to strike the correct balance. I think yeah. Hair more important, or energy, sex drive more important, I suppose. Yeah. Okay. So the different people have different kind of a perception on this. Yeah. All right. Yep. Okay. Next one, practical question. Good question. Is PSA actually, does PSA value actually double in the patient on testosterone? Do they?
No, the answer is not, because as I mentioned earlier on in my slides, that the PSA, you monitor the PSA, even if you were to give the testosterone therapy to the patient, you are not going to see the PSA jump up, double, or anything like that, because there's nothing, there's no link with each other. So what you need to do is just to find out whether the PSA continue to escalate, because you do not want to actually miss out those patients who actually have a potential of getting the prostate cancer. So that's the reason why you monitor, but it is actually has no impact on the testosterone replacement therapy.
Yeah. I think the race is not so fantastic.
Yeah, it's
one patient will show me, I think 2 days ago, on replacement, the PSA just slightly 0 point something, just a bit small difference only. Yeah. All right. Okay. Next question. Yeah. Next question. A patient with a baseline total testosterone of 11.2, 11.2 nanogram per liter, I think. Yeah. With symptom, there's symptoms. Yeah. Started on testosterone replacement. After 12 months, total testosterone was 9.5, which should be lower. But symptom-wise improved, clinically well. Yeah. It has shown improvement with the TRT. So what could be the possible explanation about that? Or what you should do about it? Yeah.
Okay, so you must understand that the testosterone deficiency syndrome is actually attributed by many reasons. For those patients who have a chronic liver, kidney disease and all these things, and naturally the testosterone level will come down. Also, you need to find out whether the patient is chronically on some other medications that actually brings the testosterone level down. So identify the cause of it, I would say that is the main important thing, because when we talk about the late onset hypogonadism, we just assume that men, as you approach the andropause, you naturally will have a low testosterone level in a normal way. But if you actually have a testosterone level that goes down, much faster than other people, you need to address the issue. You need to find out what's the underlying cause behind it. So you may not actually have a normal, andropause like what people are experiencing. So in that case, you actually can have, even though the patient is on Nebido, you can actually have a testosterone level that continues to punch down. Now, of course, when the patient is on Nebido, naturally the symptoms will get a bit better.
Yeah. Okay. All right. Thank you. Thanks for your feedback and opinion on that. So the next question is quite technical. Yeah. In TRT, what is the difference in using testosterone undecanoate versus testosterone enanthate?
So basically, when you're looking at this testosterone, there are a few formulations. So I think most of the guidelines have actually said that for oral form of a preparation, it causes a lot of liver toxicity, so it's no longer something that we would actually give to our patient anymore. But having said that, you will still have the monthly injection and also the 3-monthly injection. And of course, the monthly injection one is actually a little bit more volatile, because the patients tend to have a little bit more mood swings, and the level also can be a little bit erratic. So the 3-monthly injection is far better. So that is to address your testosterone undecanoate with the testosterone enanthate.
Okay, thanks. So yeah, I've continued. I just jump one question to the next one. Is also this technical issue one. In terms of injectable testosterone, is there any preference, which type, or depend on how frequent the patient wants, cypionate versus undecanoate? Any,
I would
you
say
probably
that
partially answered that previously, yeah, but
yes,
maybe
that's
you
right.
just,
That's right.
just
Yeah.
re-emphasize the fact. Yeah.
That's right. As I mentioned to you, I think that the 3-monthly injection is far more stable, and also it's actually a little bit more more accepted by the patient. Because you can understand that if you were to come every month for injection, and I think that not that many people really will want that unless you're talking about cancer patients and need to have this cancer drugs injection. But for testosterone, I really don't think so. Because most of the time, we will say that if you were to adopt the 3-monthly injection, it's far more stable. So that is what I would, the advice that I would give to the patient.
And it's actually easier, isn't it? I mean,
yes, it's easier.
It's actually easier, yeah. Okay, just back to the previous question in the list. Yeah, can TRT cause high cholesterol, hypercholesterolemia?
Well, to be honest with you, as you can see from the studies and all the journals that I put it up there, the TRT basically actually shows evidence that it actually brings down the lipid profile. But having said that, the guidelines say that it's still very debatable. So at this moment of time, there are many studies who say that if you were to advocate the testosterone replacement therapy, it actually reduces the chance of patient going towards a metabolic syndrome. So in a way, it's true because the later studies, like the now more recent studies, seems to advocate that. But at this moment of time, I would say that we cannot strongly establish that yet. So I would say that maybe we have to wait for more studies or stronger studies to guide us.
Yeah. Okay. All right. Thanks a lot. Thanks a lot on that. So yeah, that's the current status. Yeah, as far as that's concerned. Yeah. Okay. Okay. I will. There's one question, from the earlier. There's a long list. Just go back up there. Yeah, go back up there. Yeah, maybe we'll take this as the last question. Yeah, unless there's more question coming in. Yeah, because there are many, kind of a similar question or similar nature. But this question is important. Yeah, maybe we see how it goes. Yeah. Do we really need to check serum testosterone? That's a question. Yeah, I think it's a fine question. Yeah, or why can't we just depend on patient's symptom to know when to give the next dose? I think this is a practical question. But in fact, a few days ago, I just saw one patient who never have a testosterone test, but on testosterone replacement therapy. I think it's a very important question that we need to address. I will let you comment on that.
Right. I would say that obviously the diagnosis of testosterone deficiency syndrome come about only when the patient have a low testosterone as well as the symptoms. So you need to have these two together, because otherwise you can't continue to just give the testosterone replacement therapy, because you must understand that each of the drugs has its own side effect. And that testosterone is also a form of a steroid as well. So I would say that, yes, you may, be able to think about skipping one or two, but the thing is that as per the guidelines, you still need to actually have both. Basically, you need to test your testosterone level, and also you need to actually check the symptoms of the patients before you actually start to give, because how would you know when to stop? There are some patients who doesn't really need a long-term testosterone therapy. There are some patients who need long-term therapy, no doubt, but there are some patients who actually can just get away with just a couple of injections, and after that, with symptoms improvement and the testosterone back to normal, you do not really have to continue.
Okay, thanks a lot. Yeah, so I think that the key message here is that, before we start patient on any testosterone replacement therapy, two things, right? Clinical symptoms, yeah, symptom must fit. Second one, we must test the testosterone level, yeah, in the morning, right? What time do you tell people to test testosterone? Some say 8 to 10, some say 7 to 10. The clock all over the place. What do you advise?
As long as it's early in the morning, and that is good enough. I don't think that it doesn't matter, but some patients actually get up at about 11 a.m. or something like that.
There's a cutoff point, 11. I don't know why. Where does that 11? Maybe from study, yeah. So in the morning, we say before 11, yeah, you better get the test done, yeah. So I think beyond that, we must get these two done. The symptom and the testosterone, then we should start the treatment.
Absolutely.
Otherwise, anyway, if you don't do that, it will be kind of, they call it off-label, off-label use. It's not covered in the indication of
the product insert
replacement therapy. Okay. Well, we are supposed to stop here, but there's one important question here. I think we just address a couple more, because I think we got just spend 1-2 minutes on that before we close. Two questions. I think I just got one here. May I know what are your opinion on gel form of testosterone, the RI, gel form, versus long-acting injection in terms of convenience, in terms of efficacy? So this is the second last question. Gel form.
I think the gel form actually can promote the testosterone level to go higher, but it's not going to be as effective as the injection form. We know that. The testosterone in the form of a gel form, you have to be very careful, because you obviously know that it only lasts for 24 hours. So when you apply the time, you have to apply it right at the back there, because it's quite transferable. So if you were to, apply the gel in front and then you hug your wife, you probably will transfer the testosterone towards your wife. So that is obviously something that you do not want to, to happen. Now, of course, when it comes to the injection form, it's actually far more stable. There are some people who are worried about the injection form. Maybe they have, a mildly impaired kidney function, or maybe some, the liver disease or something like that, or maybe they're worried that they have underlying prostate cancer, something like that. Then in that case, now they will want to actually advocate a little bit of a milder form of a testosterone therapy. Then I think the gel form is good. But you must understand that it takes a long time to build up to the level that you want. It's not like an injection.
All right. Okay. I think we need some discipline as well to
start
supplementing every day.
24 hours.
Okay. Last question. I think I want to ask this one, because my chemistry not so good. This is a very biochem question. Important. Is checking free testosterone? You check free testosterone or total testosterone? What do we check for?
Yeah, I usually will check total testosterone, because I think that from most of the guidelines, we actually refer to the total testosterone, not
total, not the free one. So that is that's the parameter that we use. Easily available in most of the lab. All right. So with that, I think we will close the Q&A session. Thank you for your attention, and thank you for all the wonderful questions. I hope we all have learned some useful tips from Dr. Warren Lu. We'll put our hand together to thank Dr. Warren Lu. Yay! All right, I will hand the session back to the host. Thank you very much.